So I'm just going to make a brief introduction for each of the three panelists that are here, and then each of them will take a few minutes to come up and tell you a little bit more about their role, their position, and the work that they're doing. We then have some broader questions that I'll pose to the panel, and they can take turns answering the questions. And at about 12:35, we'll open it up to questions for the audience. So Patsy Stinchfield is an advanced practice nurse. Her credentials are here. She's a director of infection prevention and control with Children's Hospitals and Clinics out of Minnesota. Dr. Cheryl Robertson is faculty at the School of Nursing and chair of the Population Health and Systems Cooperative Unit in the school. And Dr. Deen is faculty in the Veterinary Sciences and is co-PI of the Respond Project. And I assume that the Respond Project will be brought up during the discussion. So I think we'll start with Patsy. And I'll give you my.
You do this one.
Thank you so much. Can you hear me okay, everyone? Great. It's great to be here. As you said, I am Patsy Stinchfield, and I'm a pediatric nurse practitioner. I've worked at Children's Hospitals and Clinics of Minnesota for 27 years in infectious disease and immunology, and have lived through lots of different issues with germs. So when I first started, we had our measles outbreak, the famous, infamous 1989 to 90 measles outbreak, and really sort of was shocked at how many children were coming to our hospital with a vaccine preventable disease. That got me very interested in prevention, and I kept, my new motto was prevention is better than reaction. And so really started digging down into seeing why do we have children who are unvaccinated, how did this outbreak happen? Got to be a vaccine geek over the years, and then in 2004 was honored with being the first nurse in the United States to be on the CDC's Advisory Committee on Immunization Practices, making U.S. vaccine policy. So that is really geekdom when you like vaccine policy. I'm still there as a liaison member representing the National Association of Pediatric Nurse Practitioners, and have since then dealt with things like should be able to identify, respond, refer. Then some should be assessment hospitals, and then others should be prepared to be Ebola treatment centers. And so Children's took our responsibility very seriously, very early, and we have been an assessment hospital. We're also certified by the CDC to be a treatment center. The model is now changing again, where there will be soon just one main treatment center per region, per public health region, and they want it to be able to take care of women, pregnant women, children, adults, etc. So Children's just does children, so we're out of the running of being an Ebola treatment center, but the University of Minnesota is applying for that distinction, and we wrote a letter of support for them, so stay tuned, it's them or Chicago. So part of this Ebola assessment center that Children's remains is caring for children who have just arrived in the U.S. from West Africa in the last 21 days who have fever. And if they come to Children's and they answer yes and yes, I have had international travel and I have fever, we assess them and manage them and work very closely with the health department. Since the beginning of the monitoring of all of our international travelers, we got down to the 5 airports. We have gotten weekly reports from the MDH, and every single week there's been children under the age of 18. Just this last week we went into single digits with 2 children. Before that it had been 13, 18, 22. Remarkable number of kids, and I just kept thinking it's the middle of flu season. They're going to get a fever, they're going to come see us, and they did. So I'll tell you that story in a minute. We use the Hospital Incident Command system. It's this just essentially a structure in hospitals that give you a good pattern and ability to know sort of who's on first, who's doing what, how you communicate, and I'm the incident commander of that group, and we're meeting daily for a long time, and now are down to monthly calls. But the main thing has been preparation, using this Hicks team model, having regular conference calls, looking at how our hospital, our community, our state has been responsive. We've talked to our staff, we talked to the community. We use a project management model to sort of keep all of those millions of balls in the air. One of the biggest things we had to do is just, as you all know, one of the things that was so common on CNN was the preparation and protection of people and this level 1 PPE or personal protective equipment, and that transitioned over time and then became more level 2 PPE for the actual care of a patient with a potential patient with Ebola. Our staff were very hands-on in choosing what equipment they could wear. It felt good. The belts are these papper hoods that pour in cool air and make it more comfortable. Yes, it's really nice here in the United States. And so it's this little homegrown air conditioning in there. So we did have to use this. We simulated quite a bit all of our lab handling, all of our waste management, what you do with that little kiddo's blanket that is full of blood and potentially infectious with Ebola. How do you do a chest x-ray without having the radiology tech go into the room? Lots and lots of practice and handling. And then we had our wonderful site visit from the CDC visitors. It was the same week that the Joint Commission came and reviewed us too. Those of you who are in hospitals, that's sort of one of those alone is a big week. So the CDC came in and went through every corner of all of our work and preparedness, and we thankfully passed, and we're one of the first of the 5 children's hospitals in the United States to be deemed ready to take care of a child with Ebola. So our experience, our first experience was a hoax call, believe it or not, but that was good practice. It's okay. It was right before the election, and I think people were using the "we're not prepared, we don't have equipment," and all of that political angst, which was not a very nice thing to do, but it actually helped us practice. We also had a 6-year-old with high fever who came, and the incubation period's 21 days, so we sort of did that waitful watching and waited and watched her until she was past the incubation period, and I saw her in the infectious disease clinic, and she had a usual viral illness. Then we had a real possible patient, and we call them a PUI, person under investigation, and this was a little 2-year-old Minnesotan. He was born here, and he had returned after 5 months, returned to the U.S. after being in Liberia for 5 months, and they went over there, mom, 8-year-old, and this 2-year-old went over to see their grandparents and kind of got stuck when all of the air traffic and the tickets and everything changed. The tickets became $4,000 per person to fly one way home, and had to go to these 5. So imagine, being a young parent with young children and having to come up with $12,000. So they were stuck there for a while. Came to the U.S. one day after arriving, developed this fever, and then ended up coming into isolation with all these people in these marshmallow suits taking care of you. So I feel so sorry for that family, how traumatized they were. They had originally just kind of gotten nervous and went to a local hospital, not a children's hospital, not an Ebola-prepared assessment center, so we did a transfer to us, evaluated the child, took them up to our ICU. The Ebola test was done, sent to the health department, was negative, but the child had enterovirus, just like every other kid that week. So you can tell from our planning and drilling, the picture on the left here is the original sort of drilling, and if you can see their faces, they look kind of terrified, like, what, I'm gonna do this? This is scary. But drilling and working with nurses and doctors and getting that equipment on and practicing more, that the people on the right that are smiling and waving, those were the people that actually took care of that real rule-out patient. They were ready to go, and they were wanting to practice and get it done, and they just did a great job. We also had a very important conversation on the ethics of care of children with Ebola and with the CDC on how we keep a parent and a child together versus keeping a parent and a child apart. So that's like a whole long day conversation, but there's some very challenging things when we take care of pediatric patients. The other disease I want to just show you a couple pictures is measles. It's been in the news again. Starting, and this, as you know, is like a bucket of rash poured over your head. Starts on your face, goes down your trunk and chest, down to your legs. And people are this is the only human disease, human-to-human transmission, and extremely the most contagious disease we know, 4 days before and 4 days after the rash. if somebody walked into this room right now and walked out the door and none of us were vaccinated, 90% of us would get sick just by breathing that air from them. So very, very contagious. The rash is pretty characteristic, and you want to make sure that these people don't just wait in the waiting room. They want to be brought back and cared for very, very rapidly. So we've done a lot on training and screening for our staff. And I share this icky picture, sad picture. Thankfully, this child did survive, but this was one of our 2011 outbreak patients. Our 1989-90, we had so many patients in our hospital that we took over a floor at United Hospital, and next door to us in St. Paul, moved healthy kids over there, and just essentially were overrun with measles cases. So I lived through that, and then when 2011 happened, I thought, oh no, here we go again. Thankfully, we had just 21 cases because our immunization rates were higher. We also knew how to identify it faster. But this little kiddo was on a ventilator for 15 days and did survive. This is why we vaccinate. This is why we can't let our guard down or let myths and misinformation, Facebook, really guide the day. We need to be science-based. And this mom was going to vaccinate her child, took him to a travel clinic on their way over back to see family in Kenya, and immunized all the rest of the family, and he had just fallen asleep. And she said, you know, he just fell asleep. I'm going to vaccinate when we get back from our trip. And she calls that her fateful moment, her fateful decision, despite the clinician really saying, no, today's the day. We really need to do this today. And she told me, as I took this picture with my iPhone at her bedside, take the picture, get the tubes, get the wires. All I want my child to do is wake up. And I want people to know that how dangerous measles can be. Well, thankfully, he did wake up and is doing quite well. But I think if we let our guard down anywhere in the world is so connected that measles, these kinds of things will happen in any community. So the communication about measles and just trying to get the word out and having, oh, it's just a rash, oh, I had it as a kid, and all those sort of, it's no big deal. I want to just share that picture of the child you just saw, thankfully from the mom, to remind us it's more than just a rash. And then last, influenza. We always have to be thinking about our influenza, whether it's H1N1 back in 2009, where no one had any immunity to that, and it starting as a swine flu and spreading quickly, and fear of pigs became rampant, and eating of pork that our colleagues can talk about, but even seasonal influenza. So this is a little guy who died of regular old seasonal influenza. This was back in 2013, and there were 3 normal, healthy 8-year-old boys who died of regular old influenza, and they were within about 2 weeks of each other, but they had nothing to do with each other. They didn't live near each other, go to school together. They just happened to be 8-year-old boys who died of flu. And I think it really is telling, because it was January, people had sort of stopped thinking about vaccinating and had moved on, and then the fear came, and fear is quite a driver. Drove people into our hospitals and clinics, and really needed to communicate about the importance of vaccination early on in the season in September and October. So our lessons learned when you think back on all these various outbreaks we've had is that it really starts with a risk assessment, asking ourselves, can this happen here? Can we see Ebola here? And the answer was yes, back when we asked ourselves that question in July. We have the largest Liberian population outside of Liberia. The answer is yes. Can we see measles in Minnesota? Our immunization rate is not 100%. The answer is yes. Are we going to see influenza? Well, we know how this year went with our vaccine and all, so yes. And then planning and screening and making sure we're asking the right questions, trying to identify people early who might have these infectious disease, and then practice. You just pretend that you've got a patient with measles or Ebola or whatever it is in the clinic, in the hospital, and you go through the drill. And then communication is very key. And knowing your partners before you need them. So I have the Minnesota Department of Health leaders' phone numbers in my cell phone. They have me in theirs, and we know each other well. So when an event happens, we're not just getting to know each other. And then, of course, as we said, prevention is better than reaction, because the impact to the community has happened in the past. It can definitely happen going forward, and we hope that by prevention rather than reaction that we'll avoid some of these outbreaks here at home. Thanks a lot.
I think we'll shift the format just a little bit. Cheryl, if you want to talk for 7 or so minutes, talk about your position and your role, but you know, then the experiences that you've had that have sort of informed your ideas. I think you all will touch on the themes that I have in the questions. You can
Actually,
always circle back.
why don't I just talk for a few minutes and then so for more time for questions. And you know, so I'm Cheryl. I'm a public health nurse. I work in the School of Nursing, and I'm faculty and chair of the Population Health Department. And I work with John Deen, and I'll leave that to for him to say a little bit about my area of work. And research is not in the area of infectious disease. I work in looking at armed conflict and other civil conflict, displacement, and approaches to community-based recovery from that. But that ties into all kinds of things, and and we'll have a chance to talk about that during questions. But basically, I went to Liberia this last November, December, to work on the Ebola crisis, and so I got just a couple of thoughts on that, because there is a lot of discussion about, so how the heck did this happen? What was going on? And can it happen here? It's like, well, obviously it can happen here. You know, we got some Ebola cases, and except for poor Mr. Duncan, all the folks that came to us lived. And Mr. Duncan, who went to Texas, didn't live because by the time he got treated, he was really sick. And so he didn't stand a chance. So, so how did this happen? How did this happen in West Africa? And so I look at it from a different lens. Obviously, it happened because a kid got sick, and then all the people around him got sick, and more people around him, around them got sick, and then a whole lot of people died. But it's more complicated than that, because West Africa, Liberia, and Sierra Leone in particular have been experiencing decades, essentially, of armed conflict. And what happens in armed conflict? Well, all kinds of lousy things happen. But one of the things, some of the things that happen that are directly related to this is you get, you know, the community capacity to take care of itself is profoundly affected, is broken. Civil society, that which we all depend upon to get through our days every day, from, you know, the places that you go to shop to get your food, your church, mosque, your temples, your schools, your health centers, the do-gooder groups, women's groups, men's groups, children's groups, all the things that we all do, that we have interface with all the time to keep our society taking care of itself, all gets broken down, of course. But probably most, the things that are probably most profound in terms of Ebola is looking at a broken healthcare system. And one of the things that gets targeted in today's conflicts is healthcare providers and healthcare centers. And so these 3 countries were really left with completely decimated healthcare systems. And then the other thing, and I think we don't talk about enough, is this issue of sort of a coarsening, as it were, of cultural norms. Oftentimes I think that we don't pay enough attention to what happens to communities that have experienced year after year after year of conflict. And the price of that is quite profound, and we can talk about that some more in the discussions, but where who we care about and how we take care of each other is profoundly affected after what results is kind of this sort of a culture of apathy, culture of fear. And then the very real thing of displacement. And during war, people get displaced and then end up moving into places where they don't belong, further and further into the jungles, where the dependence on bushmeat and the likelihood of exposure to really bad diseases increases. So basically, war and the resulting dysfunction and community fractionalization ends up playing a big role in this epidemic. And what do you do? How do you rebuild when everybody flees? You know, what happens in conflict, and certainly in these 3 countries, is that the best and the brightest people with connections, people with education, people who have a way out, who have relatives abroad, they flee. And as is what families do since the beginning of time, to take care of themselves and their children, so they leave. And I was in Liberia in 2002 during the war, and there was not a single functioning healthcare education program. So there were at that point 300 nurses in the whole country and 42 docs. And you know, basically there was no healthcare system, there were no standing clinics, and all of the schools had been looted and destroyed. So I come back in 2014 and 15, and again, all the schools are shut down for different reasons, and the health systems are shut down. So essentially, when I was there in Liberia, if you got Ebola, you could get treatment. If you got anything else, you couldn't get treatment. And you wouldn't want to go to an Ebola unit because then you'd get Ebola, which would not be good. And so the only way you could get any kind of healthcare services during this outbreak was if you got Ebola. Not a good thing. And so I guess there must be a thing, kind of like people taking pictures of food and put it on Instagram, as we all like to take pictures of ourselves in our suits looking terrified. So that's me looking terrified, and because I was. But it was so fascinating. As soon as I stepped foot in Liberia in last November, is I really felt like I was stepping into another conflict zone. You know, and you've got this situation where, okay, so a child plays under a tree, and where on that sort of nexus where Sierra Leone, Liberia, and Guinea meet, which has been the host of refugee crises for the last 25 years, and the ecosystem has been profoundly disrupted, ripe for a carrier for Ebola. And what's resulting is really what it looks like during conflict, where you've got people who are terrified, people who are traumatized. And that breakdown of civil society, businesses shuttered, schools shut down, churches, mosques, temples shut down, lots of dead people, lots of orphans, lots of fear, people being afraid of people who've recovered, people being afraid of people who are sick. Not good. That said, there's been lots and lots of discussion about the global response, and this is my last slide. And I tend to be kinder than the average bear. I still look at it as like, yep, it was messy, wasteful, colonial, petty, snotty, competitive, slow, uncoordinated. Just a few things, but it was effective. And I've been feeling fairly charitable about it, but I was recently John and his crowd sent me to the IOM conference on Ebola, looking at lessons learned. And so I was in DC with the WHO, CDC, and all those guys, PIH and everyone. And I felt like I was hanging out with Donald Rumsfeld. There was a lot of mistakes were made. There were known unknowns, and unknown unknowns. But nobody said we made a mistake. And that was really frustrating to me. However, the reality is, are there lessons to be learned? Absolutely. But we have a handle on the epidemic. That's it.
Okay. Yep. Thanks, Cheryl. And thank you, Patsy, as well. I'm going to take a slightly different tact. My background is as a veterinarian and an epidemiologist. And the first thing that I thought of when I wanted to portray some of the challenges is that 30 years ago, when I started taking epidemiology, I was being taught that we're in a post-infectious world, that the health concerns are going to be heart disease, cancer, and the like. Right. And yet now we're talking about infectious disease again. But you have to understand that in many ways we're talking about infectious disease in a different manner. What Cheryl portrayed was not so much disease as a health concern. many more people died from other concerns than from Ebola in Western Africa. Probably malnutrition still is at the top of the
Malaria,
list.
right, you bet.
Malaria and the like. And instead, it is that fear. And I use this as an illustration, and it struck me that in Newsweek they said, polio-related murders kill more than the disease itself. And if any of you are following, especially the health professionals that are trying to vaccinate children in especially Pakistan, a number of them have been murdered, and there's a great deal of controversy around the issue of vaccination and the like. I should also explain that my role is as one of the leads on a project now called One Health Workforce instead of Respond. And what we're trying to do is deliver on the basis of creating a workforce in these countries that Cheryl explains is missing in so many ways, and that Patsy exemplifies that we have a surplus of in so many ways in Minnesota. And in fact, one of the main reasons USAID came to us is the capacity that Minnesota shows in the area of public health. So those factors are there. We need to manage fear. We need to address why this is important. We need to address exactly how we're going to manage the diseases before they occur. And yet, there are the chances that we will exceed our capacity. If you go to the latest list of TED Talks, you'll see that Bill Gates gave a recent presentation. I think it was released about a week ago on YouTube. But he describes in great detail that what else is going to kill large numbers of people over the next couple of decades? It's most likely going to be in the area of infectious disease. Jared Diamond argues that in Guns, Germs, and Steel that infectious disease is one of the major shapers of society. It's one of the drivers, both through natural occurrence of infectious disease, but also intentional infection of people and in some cases other species as well. And we need to be cognizant of that part. But as a vet, I want to point out that controlling emergence is the third main arm of concern. And it is that contact between species that creates many of our situations and challenges that we are working through. As Cheryl said, there's a deconstruction of the ecosystem, there's a deconstruction of our health systems that occur often in parallel, and we have to address those. Whether it be Canada geese or other species showing up in our parks or in our turkey barns, whether it be pigs that we had hoped would be only in barns in the Midwest, now showing up in the countryside and having an effect. And of course, I'm not sure what happened there, but thanks. Oh, and of course, I must have touched something.
No, you're fine, just keep going.
Okay, thanks. And of course, the challenge of bats and other high contact animals in terms of contact with the human species. Emergence of diseases are going to continue to occur, and many and most argue that they're going to occur at higher frequency with encroachment and with changes in populations and with changes in contact rates, not only between people and specific species, but also between people in one country and the next, either directly or through products. The presentation last week of Drs. Travis and Kennedy lay that out in terms of risk and in terms of portrayal in many ways. And again, the opportunity we have is that Minnesota leads in many areas on that area of crossing off not only the expertise in epidemiology and public health, but also in managing food supply and other contact rates. The current epidemic of H5N2, and it can be called an epidemic now because it was called so by the group this morning or yesterday afternoon in terms of influenza in Minnesota, is such an example. We have the expertise, but right now it really is exceeding our capacity to understand the transmission paths and also the opportunities to actually control it. And we will see those challenges in the future. And creating that capacity through colleagues such as mine up front here, and through the general capacity of Minnesota and other areas, and spreading that throughout the world, I think is one of the great opportunities. Thanks.
Good question. Do I need to repeat the question, or did everyone hear that? Okay, so the measles outbreak of 89 to 91 in Minnesota, I think our causes were similar as to what was happening across the country, where at that time we just had one dose of MMR, measles, mumps, rubella, and then we realized that it was about 5% of people would not respond to that one dose, and so we added a second dose, and that would then cover that remaining 5%. It's not a booster dose, it's really a second dose of live vaccine to cover that remaining 5%. Even still, we got to 99%. We still have about 1% of people who don't respond. So that was an evolution that we realized that people, even with in our vaccine era, we had seen a big drop since the onset of the vaccine, since the early 60s to then, but that we needed that second dose. The other thing we realized was people were really not thinking about vaccines. Parents weren't thinking about it much. Clinicians weren't thinking, just if you come in, we'll give you shots. But we didn't ask them. We as clinicians, if someone came in with a broken thumb, we didn't say, okay, let's fix your thumb and let's look at your immunizations. So that moment was really that there were lots of missed opportunities on the clinician side. So we really tried to your second point about communicating, with healthcare providers, we really emphasize that every visit is a vaccine visit, to not let a child or an adult get out of your clinic or ER or wherever until you look at the immunizations. That's where a lot of the immunization registries, computerized ability to track, some laws that allow us to share immunization data clinic to clinic. That's not a HIPAA violation. So we did a lot of work with clinicians on every visit as a vaccine visit. And for parent communication, that is ongoing. Can I just say, it's a full-time job, and it really, I think what, one of the kind of overused phrases is we were victims of our own success. In some ways, immunizations have been so successful that we don't see a lot of these diseases. And so if you don't see the disease, then you kind of don't fear it, you don't have that urgency, that sort of need to get in and get vaccinated. And sadly, the way that you get that fear is if you have an outbreak or if someone dies, and we don't want to get to that point. We've had this tip of the fear of the vaccines has become greater than the fear of the disease. And we know there's a lot of myths and misinformation about vaccines. Vaccines are the most studied and have saved more lives in the world than anything short of clean water and sanitation. After that, it's been vaccinations. And so that is the message that we just have to, every day there's new parents born, I say, that have to learn about the importance of immunization. So it's really an ongoing effort.
May I just add to that?
You bet.
Thanks. And again, the vet talking, but the one thing I want to point out is the sticker that you get when you get vaccinated for influenza on campus. It says, "Do it for the herd," and it has a picture of a cow on it. I show that everywhere because it brings out 2 points. Number one is that there is a cross-disciplinary understanding of managing epidemics, but more so, the main benefit of vaccination is not to oneself, but to the community. And I think we need to take that on as a larger part of public health and the role of vaccination as well.
Great question, and it's one I've thought a lot about because in the summer we were overwhelmed with enterovirus D68 that's now we're realizing is causing some people, it's in the polio virus family, it's causing some children to have paralysis, and we were really focused on trying to figure that out. And then Ebola in Africa, we were kind of 1 year there, 1 year here, and then influenza came early, and it's just been back-to-back infections, and the amount of time and money and effort that we put into Ebola was way out of proportion for what we were actually seeing in our own backyard. But I think about what were our alternatives, and I think about the patient that we took care of that ended up not having Ebola. There's not been a patient with Ebola in Minnesota, but we have spent hours and hours and lots of money getting ready. Preparedness is sort of, you can't be kind of half in. You have to either say, is this real? Is it possible in our own backyard? If it is, then we need to prepare. And I'm well connected with other peers in children's hospitals across the country, and everyone across the country was like, what are we doing? And do we all need to do this? And it did take a while for our model to a model of care to get to where it is today. And I kept saying, boy, we're just building the plane and flying it at the same time. And that's how it goes sometimes. So I don't really throw too many stones to the people who are leading this, as we were all in it together and trying to figure it out at the same time. I'm not sure what else we could have done differently earlier on. The scramble for everyone trying to get the same personal protective equipment and those motors and things, there was an instant shortage. Trying to have fair distribution and maybe say, well, how about university settings in each state? Pick a place and narrow it down. But the public health doesn't like to tell the private side how to take care of patients. So there was a lot of those sort of dances going on too. But I think the next emerging infection is probably not known. We didn't see enterovirus D68 coming. That filled our hospital. We had record number of emergency room visits and inpatients. Thankfully, nobody died from that. We did have a child get paralyzed from it. You don't really always know. So as my last slide said, you have to have some of these principles of do your risk assessment, have your planning, be generally prepared, and be willing to work with others.
Well, I can start with that. Should we be working in partnership with countries to develop healthcare system capacity? Well, yes, of course. The issue is that it's complicated. I've been working in healthcare system development for the last 30 years in some really tough neighborhoods, and I feel like, that's a can of worms because, okay, where do I want to go with this? That's a can of worms because there's no doubt that assistance is needed. At the same time, the reason that the situation is tough as it is in countries that have struggled so much is long and complicated and convoluted, and lots and lots of aid efforts have been and are underway, and the project that John and I are involved in, the One Health Workforce now, is one of many. And it's really worthy of an entire course or a program of study to get a handle on the complexities. In terms of safety, I think that safety is a real issue, and that's something that people just individually need to decide for themselves what feels safe and what doesn't. So the way I calculate risk might be different than the way you calculate risk and the like. But I think that the issue of health system development is very key, because well, let's just take Liberia. Since Liberia's conflict ended, which has been about 10 years now, so it's not like it just happened. There's been a great deal of money and resources have gone in to assist with health system development. There have been some things that have been effective, but when this crisis hit, it was really a window was shown on these three countries in terms of how much has not been effective. And those of us in this business, go back to the drawing board in partnership with ministries of health to say, okay, what's not working, what is working. There was a movie out this weekend, the International Film Festival, called Poverty, Inc. Did anybody see that? It was it wasn't about health specifically, but it was a really interesting critique on the aid industry. And of course, I've been part of the aid industry for many, many years now, so it was very well done. I'd recommend seeing it. So in other words, it's complicated. And
I would just add a couple points to what Cheryl said, both on safety but also emergence of disease. Just to explain, Ebola has been occurring for some time now.
Right.
But it's been mostly occurring in rural areas that are so impoverished that they don't travel.
Yeah. And so not, there weren't roads, so they burn out, right?
Yep. Yeah, and that burning out has been a major part of many of these epidemics in the past. It's actually when we start seeing some affluence in a community, but superimposed upon a very disorganized and sometimes corrupt society and government, that the emergence occurs into other areas, and where, frankly, other countries start become concerned at a higher level. And that's the level of countries and actually the general improvement of overall wealth in the world has created many more potential emergencies and challenges. SARS came out of Guangdong in southern China as a community. It's probably occurred in the past, but this time it got into the city and moved on from there into Hong Kong, into Canada, and otherwise. And that's the level that we're seeing. It's probably still not going to occur in rural Afghanistan. It's probably still not going to be a nidus in other impoverished communities, but it's part of, in some cases, some of our success.
Well, I think communicating with parents is really listening first and understanding whether it's parents in Minneapolis and St. Paul, or whether it's parents in the Sudan or wherever. We are one world, and the organisms don't care what our zip code is. They don't care what the name tag, what the initials after our name are. They don't care. They will infect a vulnerable host. And so if we care about our United States zip codes, we've got to care about the rest of the world as well. Because the diseases are just a plain right away. We have to communicate that the risks of the diseases do far outweigh the risks of the vaccines. And that some of our zip codes in Minnesota and in Southern California, where the recent measles outbreak occurred, are much lower immunization rates in those areas than they are in some whole countries that have been declared, measles eradicated. And so if we let our United States, so it's sort of the flip of what you were just saying, John, is that we've got a very wealthy United States, but the disease of ignorance is contagious too. And so if we don't make sure that parents understand the facts, the science, the evidence that vaccines are safe and effective, they will stop and are stopping vaccinating their children. That is a vulnerable population. They tend to cluster together in their special school. They travel internationally. They will have a disease introduced and spread in that community. And then, as was pointed out, we always have vulnerable people. We always have, in this case, children under the age of 12 months who haven't been vaccinated yet, or, as was mentioned, children with primary immune deficiencies, or adults who are undergoing chemotherapy. So caring about us as a one world is a really important part of that, communicating with parents.
That's one of the big questions, and thanks for that. I guess I have two observations on that part. It is, to be frank, we need some fear yet of infectious diseases to prevent outbreaks from occurring. And in many cases, we have cultures that do create impediments to the transmission of disease, and we need to maintain them where at all possible. In terms of, and in development, we use disability-adjusted life years to measure health outcomes. And in very few cases, and very few examples, are infectious diseases a major health concern. I would argue that, as I said, in terms of Western Africa, crops were not harvested. Trade did not occur. Banking did not occur. These are more, as Cheryl described, in the area of disruptors, both as a function of fear and as a function of the needed control mechanisms that need to be put in place to control them. And we need to balance both in place in our behaviors. I'm not trying to diminish non-infectious diseases, but put them in a different class and understand that they have a different outcome. In that presentation that I mentioned of Bill Gates, he estimated that if we had something like Spanish flu reoccurring, the minimum cost would be in the area of $3 trillion. And not taking into account the suffering, the effect upon families, travels, et cetera, et cetera. And we have to come back to that understanding that infectious diseases can be, and sometimes are, one of the major social forces that occur still in the world.
I'll give probably an unpopular answer that I'm imagining that my colleagues here will have plenty of data to refute what I'm going to say. It's like, because, yeah. Well, can these diseases come to us? Well, obviously, it came to us. People got sick, and so the answer is yes. At the same time, I think that Ebola could have been worse here, but it wasn't going to happen the way it was happening in West Africa for all the reasons that we've talked about and a bunch of reasons that we haven't talked about. And so I'm probably not frightened enough of an infectious disease. But there was also, it was notable that there were a lot of folks who were probably more frightened than they needed to be. So probably something in between. I got frightened enough when I was on the ground in Liberia, so I certainly learned that I was capable of being quite sobered by it. At the same time, do we need to be doing preparation and all the work that Patsy and others are doing? Well, of course. At the same time, I would probably be somebody who would argue that we need to be really careful when we have limited resources with all of the issues that the health issues that our country faces. as a public health nurse, you know, there's a lot of our work has been channeled into in looking at preparedness work. That's a good thing. That's the post 9/11 response, and I would not argue that that's not a good thing. At the same time, that's been at a cost to a lot of other public health funding that also is a really good thing in terms of maternal child care and other sort of solid public health evidence-based programs that, you know, if we can't afford it all, we do need to think about what that balance is going to be. And those are very difficult conversations, and yeah.
Before we wrap up today, I want to give each of our panelists the final word of the day. So maybe just in a sentence or two each, and put you on the spot here. Where do we go from here? What's your big takeaway message from the audience today? So maybe just a couple sentences. What's the thing you want us all to be thinking about or remember when we walk out of the room today?
I would just say, remember that we are all one global community, that we're one world, and to think big like that, and that prevention of our world, our part of the world helps prevent things in the other part of the world and vice versa, and that prevention is better than reaction. Would agree?
Let's see, what would my takeaway be? That these things don't happen in a vacuum. And that they come out of incredibly complicated circumstances, and abject poverty is probably the largest driver of disease, infectious and chronic disease than anything. And
In as much as they don't happen in a vacuum, they're solved in a community, both across nations, across borders, but also within communities, across disciplines, and across individuals, not looking after themselves, but looking after this worldwide challenge that we have in front of us. Thanks.
Please join me in thanking all of our speakers for today.